Hello, dear students. The topics of today's lecture is the medical and social rehabilitation for diseases of the musculoskeletal system. In first period, in the acute period of rehabilitation, the most important thing is important of stabilization of autoimmune inflammatory process, prevention of contractures and ankylosis, elimination of joint syndrome, formation of adequate psychological response to the disease. Next, the subacute period of rehabilitation it will be dynamic monitoring, prevention of relapses, increasing the adaptive capabilities of the body, physiotherapy, massage, physical therapy, orientation of the patient to achieve maximal social adaptation. And the next chronic period is the maximum extension of remission period, prevention of relapses of disease, increasing the maintaining of level of physical performance, development of compensation mechanisms, ecological adaptation of the patient, of your condition of life and professional work. The main tasks of complex therapy with physical factors. First of all, it will be the eliminating the causes of disease progression, stimulation of metabolic processes or in affection joint, restoration of damaged tissues, and restoration of functions of affected joints. Next, this is very important, is occupational therapy in professional rehabilitation, restoration of the functional ability of joints, adaptation for the patient of new conditions. The technique should be consistent with the activity of the process and the nature of the function of the affected joints. Occupational therapy is in adverse worse conditions with tension towards body position near mechanism that's move or placed at the weight at the fast piece place or as assembly line. Treatment of damage of the musculoskeletal system is based on the following principles. The choice of the fracture treatment method is determined by the patient's general condition, age, nature, and localization of damage. Restoration with the fragment ensures the restoration of the length or shape of the limbs. Ejected fragments must be fixed state, depending on the nature of the fracture, on the limbs and treatment of patients. The course of treatment is divided into three periods: immobilization, post-immobilization, and restorative. Features of the technique. Continuity of use during the entire course of treatment. The exercise therapy methods as depending on the period of treatment. Early use of exercise therapy, which not only improves the general condition of the patient, but also prevents the occurrence of complications like the pneumonia, contraction, atrophy. Combination of treatment with the physical exercise and immobilization. Gradual increase in load, moderation of physical exercise in intense first and intensification of the third period. Use of active and passive physical exercise. Contraindicators indicators to the exercise therapy. First of all, this is general seriousness of the patient due to the blood, mental trauma, infection, and increase of body temperature with the exception of prolonged subfebrile, not higher than 37 and 5 the danger of the appearance of resumption of the bleeding due to movement, the presence of foreign vases in tissues located near large vessels, nerves, and other vital organs, the presence of other diseases that are a contraindication to the appointment of physical therapy. The period of immobilization lasts from 30 to 90 days. It is clinically characterized by the acute consequences of injury, the beginning of the regenerative process in damaged tissues, coincides with the formation of primary bone callus, provided there are no contraindicators. Exercise therapy is prescribed from the first day of inpatient treatment. General task, this is improvement of the general condition of the patient, improving the function of vital system, cardiovascular, respiratory, nervous, digestive, increasing the body's resistance, prevention of violations caused by period of immobilization lasts from 30 to 90 days. It is clinically characterized by the acute consequences of injury, the beginning of the regenerative process in the damaged tissues, and provides there are no contraindications. Exercise therapy is prescribed from the first day in inpatient treatment. General task improvements to the general condition of the patient, improving the function of vital system, cardiovascular, respiratory, nervous, digestive, increasing the body resistance, prevention of violations caused by the bed rest. Special task, improving the trophic state of the immobilized limb, stimulation of fracture consolidation, prevention of muscle atrophy, dysfunction of the joints of the immobilized limb, prevention of the mobility and contractions, development of the necessary temporary compensation form of exercise therapy, therapeutic gymnastics, morning hygienic gymnastics, individual tasks for independent classes. In case of the hip or lower leg fractures, exercises are performed with pressing along the axis of the limb on the stand or the back of the bed, and lowering the immobilized leg below the level of the bed. This prepares the leg for actual load, restores the supporting function, transverse tone. From second to third day, massage of the healthy limb, pathogenic zones free from immobilization of parts of the damaged limb, stroking, rubbing, and careful kneading. And next, this is post-immobilization period. It begins after removing of the plaster cast or scarsal fracture. Clinically, in this period, the final formation of a bone occurs. It must be taken into account that the limb after immobilization is atrophied, movements in the joints are limited, and the general task will be preparing the patients to get up if there was bed rest, training of the vestibular apparatus, learning to move on crutches, training on the reproductive capacity of the healthy. A special task to normalize the trophism of the damaged limb, for example, final formation of the bone, callus, elimination of muscle atrophy, restore movements in the joints of the damaged limb, restore normalized function of the damaged limb, restore correct posture, normalize motor skill, improve their quality. They use breathing, corrective exercise for balance, coordination of movement, static exercise for relaxation, exercise with physical activity increases due to an increase in a number of exercises and their repetition. Removal of immobilization allows you to perform active movements in all joints of injured limb. Physical exercise for people with numerous fractures, according to you can see in these pictures, and special exercise for people with elbow joint injuries and position correction. Movements on the polished panel, swaying in the elbow joints, movements using rolled cards, bending in the elbow joint with the support of the healthy hand, rolling of the stick, swelling in the stick, and placing the hand between two sandbags. Physical therapy for spinal fractures. The course of physical therapy is divided into 3 periods and begins a few hours after injury and immobilization and lasts an average for 3 weeks. Second, the next 2 weeks, that is until the end of the first month, and third, during the second month after the fracture. As the period task, improvement with psycho-emotional state, assistance of establishing the injured vertebra in the functional starting position, moderate to back muscles, improvement of blood circulation, prevention of pneumonia, activation of intestinal persistence. The features of therapeutic gymnastic. The patient performed movements with his hands and feet without taking his limb off the bed and are not to display the injured vertebra with energetic movement. Perform light limb movements and breathing exercise. Second period includes features of therapeutic gymnastic, energetic exercise for the muscles of the shoulder and pelvic full load inappropriate movements are carried out which each leg separately. Training for of the back muscles extensor complex exercise are not prescribed and special exercise are not performed full. And in the main principle of conducting classes is not painful movement. All movements are facilitated but inclined position in the bed. And third period, exercise are performed that require good coordination of movements and significant strength, included exercise to develop flexibility of the spine, lateral tilts and rotation of the spine in the longitudinal axis. Perform intense bending with a large amplitude and weight. And by the end of the second month, some crunching movements are included, which include the flexibility of the spine, movements while standing on the knees, and movements with a small support of the leg. And next, this will be the control of effectiveness for physical for back muscle cannot carry out with help of the test. So now I will share with my screen, and I will show you small video how to about the rehabilitation process in patient with trauma. And now I will share, and so you can watch this video from your screen. So please watch this movie.
Stretching out this hip. I want you to keep your balance. Try to pull in your abs.
Yeah, I lose it.
Okay. What you're going to do is you're going to rotate your body, both hands. You're going to reach down, grab the kettlebell. We're going to help you come up. Come all the way up. Grab, rotate, rotate, and then put it back down. Okay? Don't worry about me. Just do your thing. Got it. Go. Come on. Pull in your abs. Pull them in, pull them in, pull them in. There you go. Okay, up tall first. Up tall first. Come on. You got this. Head up, chin. Rotate. Up tall. Abs in. Abs in. Don't lean back. There you go. Don't be nervous. You got it. You got it. You okay?
Yeah, it's all spazzy.
Okay. Okay, I think I could use some practice. It's okay. Go ahead and let go. Oh, I got you. Just use your trunk. There you go. Abs nice and tight because I want you controlling all through here. All right, I don't want you using your arms to push up.
Okay.
Understand?
Yeah, that's what I was doing so much on the other side.
Okay. A little bit, but I wasn't going to throw you under the bus. Ready?
Yeah.
Okay. And Dan, I want you to hold right there. Okay, much better. Okay, reach out. Okay. Tuck a chin. Beautiful. Back. And down. Squat down halfway. Come. Lift up. Rotate to the left. Rotate to the right. Come back to the middle. Okay, okay, squat, up, come on, up, 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 up. Nice. Up a little higher. Everything, butt and arms. Good, and down.
Okay, you saw this video. Now I will share with another video about the rehabilitation process of the patient with pathology of muscular skeletal system and how this is the work, so work therapy in patients with pathological with problem of musculoskeletal system. So I'm sharing with my screen, and you can watch this video, work of the skeletal therapy.
Keith is going to transfer from his wheelchair into the rewalk. Ideally, what's going to happen is he's going to transfer onto the right leg of the device and then another scoot to transfer all the way in. Okay, and I'm just here guarding the device and maybe assisting Keith a little bit if he needs any, but he's pretty good. Okay. Hang on one second, I think I forgot to unclip these.
Nearby, or you got it?
Sure, you can, yeah. Yes. Okay, that's better. Nice. Good, lift up and there you go. Very good. Great transfer. Okay. Yeah, push down on that knee.
They use the strap, right?
They did. Oh yeah, she made the strap longer.
Nice.
So when Keith is ready, he's going to do a sit to stand. Okay, he's going to press the controller on the watch to change it from the sitting position to the stand position. He's going to take both crutches, he's going to bring them behind him and tuck them in, lean forward, and the device is going to help him stand up as he leans forward.
Okay. Standing.
Good. There you go. Keep coming forward. Bring the crutches forward. Good. How do you feel?
Good.
Okay, let's go right into walking.
Okay.
Whenever you're ready.
Going well. Okay.
Good, look up. Look up over my head. Good, keep your head up. Good, and try to shift with the hips coming first. Good. Very nice, keep the head up. Good, and scuff to stop. Nice.
Hey now. Okay, let it.
Good, find home.
Okay. Okay, getting the home.
Good.
Now I found home.
Okay. So we'll turn, which side do you want to go?
You know, I do neglect it a lot. I guess we'll try left.
Okay,
I do.
sounds good.
It's a little short of a turn. Okay.
Okay. So to turn, Keith is going to bring both crutches to the side, weight shift to offset one of his legs, and then use the crutches to pivot and turn.
Not really good. Yeah. Gotta get more on your heel.
So you only shift as little as you need to lift up the opposite leg.
Walk. There we go. A little walk.
That's it. Look up. Good, look up. Keep your chest up. You're going to shift forward with the hips leading. Better. Nice. Look up. You decide when to stop.
1, 2, 2, 3.
Very nice. All right, let's sit. Good. Throw the crutches back. Good. Try to lean forward as it goes down. That's it.
So you saw the video of rehabilitation, of different type of rehabilitation of patients with problems with musculoskeletal system. And now I will share with my screen to continue our presentation about the rehabilitation process of patients with musculoskeletal disease. Control of effectiveness physical therapy of the back muscles can be carried out with the help of a test. The patient is offered to hold the body in the swallow position, lying on the stomach, move the hands back, raise the head and shoulders while simultaneously raising the straight legs. The test is satisfactory if patient holds this position for 2 to 3 minutes. For abnormal muscles lying on the back, raise your straight legs at the angle for 45 degrees. And the test is positive if the patient keeps the legs for 2 to 3 minutes. Next. After 45, 60 days after the injury, the patient is allowed to get up. When getting out of the bed, the patient should not sit down in a prone position. He moved to the edge of the bed, lowers the legs lying on the angle of the bed, and placed it on the floor. Leaning on his hand, put the second leg and straightens up. Gradually includes exercise performed from the initial standing position, body tilt, alternative abduction and adduction of legs, half squat with straight back, lowering from heel to toe. The functional state of the spine must be checked for months after the injury. With positive results, the clinics and X-ray examinations, the patient is offered to perform exercise from the starting position while standing. Functional assessment of the spine. Raise your hands up, bend back, and strengthen your arm forward, bend your body with a straight back. Medical and social rehabilitation, our surgical intervention of the thoracic and abdominal organ includes a different type of rehabilitation, and in the acute period will be normalization of the functions of the body system, prevention of septic conditions, medication, prevention of congestive pneumonia, intestinal atony, congestive and thromboembolic complication, though early physical activity, through early physical activity and physical therapy, acceleration of regeneration and repair processes, prevention of formation of abdominal and pleural adhesion. Task of the subacute rehabilitation will be about the normalization of functions of my body, prevention of septic conditions, and in case of the next, we will talk about the spinal cord injury. It's attributable to trauma caused by accidents like car crash, falls of sports such as diving or gymnastics, and violent causes like the different injury by cold weapon, and also caused by non-traumatic cause like the primary and metastatic tumors, compressive myelopathy such as cervical spondylitic myelopathy, neurodegenerative diseases such as motor nervous disease, autoimmune disease like multiple sclerosis, infections such as epidural abscess, and vascular diseases such as medullary infarction, as well as genetic causes, for example, spinal muscle atrophy that affect spinal cord motor and sensory function, often causing neurogenic bladder bowel. The global prevalence rate, including the both traumatic and non-traumatic causes, in 40 to 80 cases per million people. However, 90% of cases are due to traumatic causes, which with a male-to-male ratio 2:1, respectively, presenting with bimodal age peak of young people and 30 years old people. To estimate the economic burden, the first year after injury treatment cost is estimated to be more than $300,000, rising for more than $1 million. The main causes of spinal cord injury are vehicle accident, force violence, compressive myelopathy, tumor, and multiple sclerosis. More damaged anatomical regions are the lower cervical spine, cervicothoracic union, and thoracic lumbar union. Prognosis depends on the level of injury. Evaluation assessment tools in rehabilitation. There are several tools to assess the patient with spinal cord injury. Some of them are the following: ASIAL scale, spinal cord independence measure, skin cells, working index of spinal cord injury, second scale, and short form health survey, SF. Quality of life tests. There are very useful instruments that easy decision making on treatment and rehabilitation, taking into consideration patient capacity and expectations to integrate into society. ASIA scale has a scale developed by American Spinal Injury Association and is considered the gold standard for spinal cord injury clinical evaluation. The scale significantly relates to its capacity to determine the level of injury, whether it is a complete or incomplete injury, predict prognosis, and serve as guidance for treatment. It consists of the examination of dermatomes and myotomes. For evaluation of sensory function, 28 key dermatomes are explored during the piece of cotton or monofilament. For motor examination, 5 upper and 5 lower key muscle groups are evaluated. S5 to S5, S4 to and S5 dermatome evaluation is useful to determine if the injury is complete or incomplete, but looking for the external and sphincter contraction and anal pressure sense. Asia A, complete, no motor and sensory function. Asia B, incomplete, no motor, sensory function present, no motor function below the level of injury, including S5-4 to S5 level. C, motor function present below the level of injury, and more than half of key muscles below the level of injury will less than 3 or to 5 strengths. D, incomplete, it will be motor function present and below the level of injury, and at least half of key muscles with strengths more than 3 to 5, and E, normal sensory and motor function. And now I will, according to the Asia scale, an occurrence prognosis can be established in if the 72 hours post injury evaluation 50% versus an A-type injury will remain in this classification. Meanwhile, 10 will convert into B-type injury and the 10 remains will convert into C-type injury. From the conversion percentages, only 14% of patients will gain some aided gait capacity. Patients with B-type injury are considered to gain 33 of gait capacity. C-type injury will gain approximately 75 of gait capacity, and D-type injury patient will have a good prognosis, since most of them will be able to work in 1 year post-injury. Now I want to share with the screen and show you the Asia scale, how it's look like, how to say, how to test this scale in practice. For this is gold standard for Asia scale, and this is very important scale to assess the patient. So I will share with my screen, and you can see this visual scale. So I will show you a small video about this axial scale. Now I will share with my screen so you can watch how it looks like this axial scale and how to check the patient with this axial scale. So
from that. And based on that, the there's a Frankel class of patient impairment scale that is given A, C, and D, and sometimes be very confusing. And it's probably just to deal with the beginning and the end. A, that is, there is nothing preserved below a certain cord injury. There's no sensation preserved. There's no motor that's preserved, even including the sacral segments, the rectal exam for sensory and motor. E is completely normal, full sensation everywhere. And in between, it gets a little confusing. For B and incomplete, has sensory but no motor function preserved below the neurologic level. This is kind of classic if someone has a high or mid injury, and they might have like a bicep that works or something, but nothing below that. And if they have no perirectal sensation, then that is the sacral element, S4 and S5, then that's complete. If they do have sensation, the sensory is preserved. And C is incomplete. That's motor function reserved below the neurologic level, with greater than half the muscles having a muscle grade less than 3. So still a pretty poor exam. And D can actually be quite good. It's motor function reserved below the neurologic level, greater than half the muscles have a muscle grade greater than 3. And this can even include something like, oh God, like a 4 to 5 on your right wrist, and that's it, like a 99D on your exam or something like that. And so the initial evaluation, and not much has really changed over the years. Folks will present, and this is post-resuscitation recovery and assessment, that if they're an A complete on an assessment, really 10% or less actually eventually recover the ability to ambulate in some way. Often this is with braces, kind of very stiff metal braces on your legs and things like that. And the B incomplete is 33%. So that's a huge difference. And it's it seems like you're seeing, and quite honestly, the sensation, the perirectal sensation, the difference between that and an A, that's really it. The threefold and the possibility of being able to ambulate over time. This is assuming the best of care. And C is the incompletes, and about 75% Ds, given that they were relatively minor overall, they generally do quite well. And so just some classic landmarks that you guys I'm sure have heard about. T4 sensory levels about at the nipple, the T10 is at the umbilicus.
hey everyone. So you watch this video about spinal cord injury, about the axial scale, and now we will continue our lecture and we will talk about the spinal cord injuries and about the next axial. It will be the skin scale. Spinal cord dependence measure is a tool that assesses the spinal cord injury patient capacity to perform daily life activities. This instrument in 19 areas and contains 4 subscales: self-caring from 0 to 20 pose, Breathing can swing to control from 0 to 40 points, room and bathroom, mobility from and until from 0 to 30 points. Besides these subscales, feeding, bad mobility, pressure, ulcer prevention, and from wheelchair and floor are included. The maximum score to obtain is 1 point. A high score means the patient is dependent for daily life activities. This is a self-assessment tool, so there is no need to qualify personnel to evaluate it. Next, the walking index for spinal is a reliable and a trustworthy tool to measure walking improvement in spinal cord injury patients. High levels and evaluate the gait, considering the use of walking aids. It goes from 0, the patient is not able to walk, to 20, the patient walks at least 10 meters without crutches or assistance. SF35 short form health history questionnaire is no specific generic test broadly used to evaluate the quality of life, considering both positive and negative subjects in patients with chronic conditions and mobility diseases. It is easy to answer and takes approximately from 5 to 10 minutes. Rehabilitation strategies. Spinal cord injuries is neurological conditions that demands a long rehabilitation period coordinated by a multidisciplinary team because of the damage that it entails, to avoid complications as much as possible, to improve function and to achieve the most independence. Numerous rehabilitation strategies have been shown in many studies to have an impact in patients' recovery. Some of them are the following: strengths, movements and stretching exercise, functional electrical stimulation, epidural electrical stimulation of the spinal cord, occupational therapy, dry needling, and exoskeleton. A range of movement, strength, and stretching exercise. A range of movements refers to the normal movement of joints, and studies are observed that this exercise improves function for daily life activities, prevent contractures, protect and the muscles, promote cerebral remodeling, and improve spinal microenvironment and functional prognosis. For protection of the jaw structures and preventing of muscle tones, sandbags, pillows, or orthoses are usually used. Exercise is important to strengthening the muscles of upper limbs, or on rotation of the shoulders, for use the crutches or wheelchair. This exercise will help in the mobilization and independence of daily life activities. Patient with incomplete spinal cord potential is high, so sitting, parallel bars, balance exercise should be done. Functional electrical stimulation is a technique that artificial systems through electrical pulses, producing actions potentials in the efferent and afferent neural pathways to stimulate muscles and generate movement. This procedure is added to other therapies to increase mobility, sensory feedback, and muscle activity to decrease atrophy. It also provides cardiorespiratory improve posture and trunk stability, prevents contractures, pressure ulcers, and orthostatic hypotension, promote nerve restoration, and prevent peripheral nerve acceleration. This procedure is added to other therapies to increase mobility, sensory feedback, and muscle activity to decrease atrophy. It also provides cardiorespiratory fitness, improve posture and trunk stability, prevent contractions, pressure ulcers, and orthostatic hypotension, promotes nerve restoration, and prevent peripheral nerve deterioration. Epidural electrical stimulation of the spinal cord. This strategy requires and through laminectomy over the dura mater of the spinal cord. The device delivers a rhythmical afferent electrical current to posterior nerve roots to activate central circuits that regulate movement, pain, and the cardiorespiratory system. It is believed that epidural electrical stimulation activates two pathways. The first one stimulates afferent dorsal pathway that synapse with the motor neuron. The second pathway directly stimulates motor neurons through stimulation in afferent motor nerve. Studies in spinal cord injury patients have shown that this strategy decreases fatigue, improves cardiovascular and respiratory fitness, increases lean body mass, and improves blood voiding. The main disadvantages of the electrical epidural stimulation are that it requires surgery for device insertion, which implicates the risk of infection, hematoma, or injury because of the device. It is expensive and it does not yet establish a standard number of sessions and parameter configuration, since multiple studies have shown that outcomes vary in each patient due to spinal cord heterogeneity. Transcutaneous electrical nerve stimulation TENS is a high and low frequency electrical current therapy. It is used for pain management, but many other benefits can be observed, such as balance and proprioceptive improvement and spasticity decrease. To date, its mechanism of action is unknown. However, different theories assume it works by modulating inhibitory spinal circuits, by activating afferent neurons, or by inducing central nervous system plasticity. By applying it, it is necessary to consider electron positions, frequency, and pulse intensity. Though there is not a consensus on how long sessions should be last and how much frequency has to be applied. The main advantages of this therapy are that it's low cost, it is easy to apply, so the patient can do it herself, and there are no side effects reported yet. Occupational therapy is a crucial process in rehabilitation since it is a social role farming. It focuses on enhancing daily life activity, execution, and fine movement by searching for total dependence or performing compensatory strategies to adapt as well as patient's environment adaptation, home transportation, or workplace to achieve total inclusion with its remaining abilities. It demands equipment and techniques for transferring from one surface to another: dressing, bathing, grooming, feeding, cooking, respiratory exercise, and physical and intestinal control. Besides, it also trains on wheelchair use and provides counseling for home modifications like ramp addition, bath chair incorporation, and current installation. Dry needling. Dry needling an invasive procedure that consists of reaching muscles, myofascial triggering points with a needle. Myofascial trigger points are small, tense muscle nodules that cause pain, causes weakness, and limit range of motion. It is considered that dry needling stimulation inhibits spontaneous electrical activity in myofascial triggering points by diminishing the availability of acetylcholine in the motor and plate. It is believed that MTP originates here. Consequently, muscle fiber relaxes, promoting pain, spasticity reduction, and improving gait speed and stability in patients with incomplete injury. It is worth mentioning that more studies have to be made to set the frequency, duration, and intensity of sections to obtain a desirable outcome. Exoskeleton are battery-powered robotic devices that just to the patient's limb. It can be operated with manual or oral control or microenvironment detector to easy mobility and gait. Two main objectives of the exoskeleton are promoting recovery through repeated movements to increase neuron plasticity, and assist mobility. Rework, for example, or Indigo art community use exoskeletons that enable walking, sitting, and climbing stairs up and down. The use has shown improvements in quality of life, body composition, bone density, neuropathic pain, and spasticity, and an increase in gain speed, number of steps, and distance just before and after 90 days of training. Restraints for certain users are height, weight, articular rigidity, and high cost. Electrical stimulation outcome measurement can be performed through different methods depending on evaluating function. After in orders in different outcomes can be measured through motor task performance such as sitting and balance and body fat mass measurement, respiratory function, and all this compared before and after therapy application. Cardiovascular rehabilitation crucial for daily life activity, very important, but are not enough to preserve cardiovascular safety. Systematic the presence of cardiovascular disease in patients with spinal cord injury is 60 to 70%, and this represents just an able population and main cause of death. Besides, level of injury is higher, so will be risk of this. Another detail, the patient with trauma, a high risk of complications such as thromboembolism, autonomic dysreflexia, orthostatic hypotension, pain, and cardiac atrophy. Cardiovascular self. For cardiovascular status and enhancement in the spinal cord injury patient, she suggests to do body-wide supported training for it has advantageous effect on cardiac rate and blood pressure. Do upper limb exercise with moderate to strenuous intensity 3 days a week for at least 3 weeks, and train with functional electrical stimulation 3 days a week for at least 2 months. This kind of training improves the patient lipid profile because it reduces triglycerides and lipoproteins cholesterol. Orthostatic hypotension after a long resting period, patient may suffer orthostatic hypotension. It will be tilt table can be useful to get patient used to vertical position with a gradual beginning until tolerance of position is achieved. Afterward, patients should sit on the border of the bed by their own 3 or 4 times a day to keep balance. It is important because the position is needed for wheelchair use. Glycemic control. For optimal glycemic control, aerobic exercise 30 minutes per day, at least once for 8 weeks is recommended. Autonomic dysreflexia consists of sudden blood pressure elevation caused by stimuli such as bladder over distension or lack of bowel moving, take closer or pressure alters. Its systolic blood pressure increases to 2 to 4 hours the baseline and occurs with injury over level T6 and high upper. Happens because the previously mentioned stimulus start uncontrolled adrenergic response due to abnormal supraspinal regulatory signal causing blood pressure evaluation and bradycardia as the compensatory response. And this is an emergency since it is caused serious complications such as hypertensive encephalopathy, cardiac arrest, and even this is from pharmacological treatment. We should use nitrates, nifedipine, prazosin, capsaicin, and botulotoxin. Pulmonary rehabilitation is critical in the acute chronic phases of spinal cord injury, particularly in patients with high-level injuries because there was system eating thoracic expansion, low pulmonary volumes, and weak cough. previously mentioned issues because hyperventilation, mucus plugs, surfactant decrease, pneumonia, arterial studies, or respiratory fractures. It may result in death if not properly cared. Additionally, due to respiratory mechanisms, compromise certain voice characteristics are affected, such as less syllable production per breathing, less volume, and more roughness. The next section discusses the strategies to improve postural changes and early mobilization, breathing techniques, spontaneous cough and cough aid, secretion management, and respiratory muscle training, and finally percussion and vibrational therapy. Now I will show you a small video about spinal cord rehabilitation, about the rehabilitation of the traumatic spinal cord, and how we can help to these patients, and how we, for example, we can revoke walking assistant device. Spinal cord. Now I will show you a spinal cord and a spinal cord and rehabilitation. Now I will share with my screen and show you some different exercise. And for example, very important to have the rehabilitation and at their home. And I will show you now how we can help to such patient, for example, in their homes, and how can we help them. Now I will show these small videos. For example, very important to range of therapy. This is about the spinal cord rehabilitation, and we can use different techniques in, for example, in water. And this is very important that we can use different type of techniques. Now you can watch this movie.
So we're going to try to do the same.
Same thing, yep. First, let's just start with finding your center. Okay, tighten the core, here and here.
2, 3, 4, 5.
There you go.
8, got it. 9, 10.
Good. You're gonna do both crutches, left, right. Both crutches, left, right. Okay? Left, right. Crutch, left, right. Crutch, left, right. Good. Good. Squeeze and scoop the hips underneath you. Good. A little wider with the crutches. There you go. Good. Good. Bring the hip back. Ooh, nice. Good.
What was that, 7?
Yep. Good. Stand up nice and tall. Good. Good. Deep breath in. Good.
Starting treadmill in 3, 2, 1. You're at a minute and a half, 55% body weight support, speed 1.6. Shift to the right, left leg up, squeeze here, body nice and strong and tall, hold it. Shift right, left foot down. Good, even weight. Shift left, squeeze that left knee, left hip, right up. Hold it. Left hip strong. Right foot down. Good. Squat down. Come forward all the way up. And down. Good. Hips forward. Step. Hips forward. Step. Good. Quick feet.
Lock out that left knee. Good. Squeeze the hips, bring them up higher. There you go. And rest. Good. What was quads? Okay, so for this one, everything's going to kind of start contracting together. Okay. You're going to try to squeeze your glutes, lift them up, and just translating your knees forward, okay?
Okay.
We're going to do a set of 10. Ready?
Yeah.
Go. So up. Squeeze. Nice. Hold it. And down slow. Can I make it a little faster, okay?
Yeah. 10 of those.
It's all about the control and the endurance of these muscles. Up. Squeeze, squeeze. Lift them up as high as you can. Good. A little longer. And down. Controlling on the way down. Good. Curl up. Good. And down. That's the pattern, okay? Curl up. Good. And down. Up. And down. Rest.
Okay. So you saw the different form of rehabilitation process in patients of different with spinal cord injury. Now we will continue our discussion, and I will share with my screen to continue my presentation. So as you saw, there are different type of exercise which we use in patient with different form of a different level of spinal cord injury. And what is more, we sometimes use and transcutaneous nerve stimulation and different movements in parts of the levels, training of the bells, and what is important, we are training the patient of we're using the neural facilitation, for example, technique, and this is a technique which we used in rehabilitation processes with patient with pathology of the spinal cord injury, different levels of the spinal cord injury. And what is more, we body weight supported treadmill training. This is functional movement training in which the patient stands over a treadmill with harness, aids by therapist to move the legs and keeps balance. It can be beneficial since it is an aerobic exercise. And next type of rehabilitation, maybe we discuss about this type of rehabilitation in previous lections. This is the Bobot therapy, which includes difficult type of rehabilitation techniques. And in this case, this is a group of complex, specific, and individualized techniques based on postural control and task execution, taking advantage of neuromuscular plasticity to achieve problem solving in people with movement disorders. It's possible to control posture, reduce plasticity, increase muscle tone, improve standing abilities through these methods. Neurogenic bladder. This is another one problem in patient with this pathology, and we should talk about this technique too. And in this bladder, neurogenic, up to 80% of patients suffer neurogenic bladder as a result of detrusor hyperactive disorders, sphincter dyssynergia, and detrusor areflexia. They have an increased risk of urinary incontinence, recurring infections, vesicular uteral reflux, and renal and bladder lithiasis. Most of patients will need management of dry and complete voiding to ensure the low pressure reservoir function of the bladder. This management begins with anticholinergic medication and intermittent catheterization. Patients who failed this treatment need more invasive treatment, such as sphincterotomy, botulinum toxin applications, stent sections, imaging, and urodynamic studies should be performed for the initial evaluation of the patient. Catheterization technique should be done too. So for this, we will finish our lecture about the spinal cord injuries, and now you know that this disorder is very important, and very important is psychological management in patient with spinal cord injury, because all of them have some psychological problem like depression or anxiety, and psychotherapy should be helpful to provide the most support, educating development of new skills, and minimize social um, aversion. And so such patients should be checked if they have such condition. And this now we will finish our lecture, and should know that this multiple disciplinary team should be involved to reduce possibility complication in patient with a spinal cord injury. Many thanks for your attention, and bye bye. Компьютером. Херня.